Good afternoon. Welcome everyone to Garfunkel Wild's webinar entitled Telehealth, Effective Risk Management Strategies to Reduce Liability. My name is Barry Sapelowitz, and I'm here with my partner, Roy Breitenbach. This is the first of several webinars we plan to provide covering different areas of telehealth. Now, certain issues that we will discuss today, such as privacy and confidentiality, prescribing and reimbursement, will be covered in greater detail in later webinars, so we're only going to focus on the risk management component today. We have attendees from all over the country, so we're not going to be state-specific in our presentation. If you have any questions that are state-specific, we invite you to call or email us. We will be showing slides during the program which identify the topics to be discussed. These slides are not meant to be a standalone informational document, so if you have any follow-up questions, please feel free to call or email us. A copy of the slides and the recording will be sent to everybody at a later date. We're very pleased to present this exciting area of healthcare. Advocates of telemedicine have always claimed that telemedicine is a methodology that would permit increased access to care, and with ongoing improvements in technology, we have seen this modality being used to monitor chronic conditions, manage disease-specific populations, enhance data collection, increase patient compliance, reduce admissions, and with slowly expanding reimbursement, we are seeing more and more health networks offering telehealth services with increasing range of services. Insurance companies are using telemedicine and telehealth to link their insureds to other providers when their usual physicians are not available. We are seeing kiosks in gyms, airports, and resorts linking people to nearby medical facilities. Over the past few years, states have been introducing hundreds of telehealth-related legislation relating to licensure, prescribing, standard of care, and informed consent. Yet there are areas of legal exposure and liability, some similar to what you deal with in traditional healthcare, others more unique to telehealth, but there are strategies that can be implemented to reduce and manage these risks. There's a lot that we're going to be covering today. Today we'll be providing you with a roadmap of the risk management issues, and many of these topics that we're discussing today will be discussed in further detail in later webinars.
Okay, so this is Roy Breitenbach. Good afternoon. I'm going to talk a little bit about definitions first, right? What is telehealth? So, people talk about telehealth or telemedicine and use the term interchangeably. And you can do that, but generally, most of the commentators talk about telehealth being the broader topic, to pick up not just what you would think of as remote medical care, like through Skype or through some type of two-way technology, but also health apps, wearable apps, things like that. So telehealth tends to be the broader topic, whereas telemedicine is the more narrower topic, and we'll be using the terms as appropriate. What the American Medical Association defines as telemedicine, and that's the term that the AMA uses most predominantly, is the use of information technology to provide clinical health care from a distance. And that's the concept. You're providing clinical health care from a distance. There's an originating site where the patient is located, and then there's a distant site where the healthcare professional that's providing the treatment is located. And those are the terms that will be used most frequently. One of the most important organizations for telehealth or telemedicine is the Federation of State Medical Boards, because as Barry will explain in a little bit, the licensure issues regarding telemedicine are very broad. So the Federation of State Medical Boards have updated its definitions over time and has become more accepting of the concept of telemedicine. And their definition is the practice of medicine using electronic communications, information technology, or other means. And then finally, we'll talk about CMS, which has its own definition, and it talks about that it's a two-way, real-time, interactive communication between the patient and the distant site physician. And, this two-way concept is a key concept. Most of the telemedicine issues that we're going to talk about concerning risk management, informed consent, and things like that really presuppose two-way, real-time, interactive communication. And that's the focus. So let's now go to the next slide.
Okay, so other terms that you're going to be hearing are the terms synchronous or asynchronous, store and forward, and RPM, remote patient monitoring. So synchronous communications are real-time communications. This typically involves two-way video, audio between the patient and the physician. It allows immediate feedback and many states, again, a lot of this is very state specific, actually require this form of communication in the telemedicine encounter. Asynchronous communications frequently is referred to as store and forward. This is not a real-time communication. There's a lag in time between sending the information and the interpretation. Therefore, it may not be immediate. Typically, diagnostic information is recorded or captured at the patient site and sent to the specialist in another location. For example, an X-ray sent to the radiologist at a distant site and is interpreted later on, and the findings are recorded in the EMR of the originating site for review later. Or a patient uploads his or her record via a patient portal to the doctor to review later on. Now, some states will permit this form of communication if certain requirements are complied with, for example, having appropriate security, complying with certain standards, and obtaining and recording patient consent. We hear a lot about remote patient monitoring. This may allow earlier detection and intervention for patients who are suffering from certain chronic conditions, such as diabetes, congestive heart failure, COPD, chronic obstructive pulmonary disease, asthma, and certain mental or behavioral conditions. Here, data is sent from the patient site to the hospital or to a physician practice or to a monitoring facility, and it may involve both synchronous and asynchronous communications. So, for example, you may have certain data that is transmitted in real time for immediate review, analysis, and decision-making, and other data can be reviewed later on to monitor the overall chronic condition of the patient. Using RPM with the patient at home, you would think is a natural fit, but you need to confirm whether the patient's home is an appropriate originating site for reimbursement or other purposes. Many Medicaid programs may exclude a patient's home, but a significant number of states are now permitting the home to be an eligible originating site under certain circumstances.
Okay, so it's important to understand what's included within the definition of telemedicine, but what's also excluded. Based upon the CMS definition and what the AMA considers, telephone communications, email, instant messaging, and text communications by those means do not constitute telemedicine and do not fall under the telemedicine rules. And in most of those situations, the AMA, the Federation of State Medical Board model policies, and CMS certainly wouldn't consider interactions by these modalities to qualify as establishing a physician-patient relationship or constituting or falling within the telemedicine definition. There are some states, however, which have loose enough language, who've gone beyond the Federation of State Medical Board model policy, that would consider conversations via telephone, email, instant messaging, or text to fall within the definition of telemedicine. And actually that it raises a very interesting risk management issue, which is practitioners have to be careful that they're not inadvertently creating liability or a patient-physician relationship when they're communicating purely answering a quick question by email or things like that. Particularly in the area of privacy, it may raise some issues. You may be answering a quick question via email with a patient, and in some states that may constitute a telemedicine interaction, and therefore you were supposed to have certain privacy restrictions in place, and we're supposed to get certain informed consent. So care has to be taken to understand your particular state's definition and to make sure these kind of informal communications do not constitute telemedicine.
All right, so let's talk a little bit about licensure and credentialing. These are important risk management issues. Licensure is not treated by state statutes in a uniform manner, and you also have state boards of medicine regulations. You have state disciplinary action. You have state attorney general actions and decisions. Generally speaking, the telehealth provider should be licensed in both the state he or she is located and where the patient is located. The majority of states to date require the out-of-state provider to have full licensure where the patient is located, because most states have taken the position that the physician is practicing medicine in the state that the patient resides or where the patient is located. And this can create an administrative burden on the physicians or on the facilities that are providing telemedicine or telehealth services. Now, some states have, these special purpose licenses or certificates, but again, these may be limited to telehealth and telemedicine. It's a very limited license. It may apply to specific services. You need to meet certain criteria. or you may have border state exceptions that allow physicians or other providers to come in from a bordering state. We hear a lot about consultation exceptions. These two are very, very limited. The encounters, if you look at the various state laws, they use words such as infrequent, limited, occasional, irregular, or on an emergency basis. So not only must the doctor comply with certain requirements, but these are very, very limited encounters and are typically not helpful in the type of situations when we work with our telemedicine providers. The Federation of State Medical Boards, which I believe Roy mentioned earlier on, they have created, or it has created, what's called an Interstate Medical License Compact. To date, roughly 29 states are involved, and what happens here is that this tries to alleviate some of the complexity and the burdensome administrative work in getting multiple licenses. So here, a physician can receive a license in another compact state. You have to be a member of the compact through an expedited licensure process. So you still have to get a license. You have to meet certain criteria involving education, certification, and disciplinary history, but it makes the licensing process easier. It does not eliminate it. And the state board, the state medical board of the state, still retains authority over the out-of-state physician. So you still have that control aspect of the state where presumably the patient is residing or is being treated. There are other compacts involving nurses and physical therapists and telepsychologists that may be appropriate to look at it, depending on the telemedicine or telehealth encounter. With respect to privileges and credentialing, these are requirements that are promulgated by the CMS Medicare Conditions of Participation, by the Joint Commission, by state law. And if you're dealing with hospitals, the originating site hospital, this is the hospital where the patient is located, it is responsible for granting the privileges and credentialing to the distant provider. Now, the originating site hospital, again, the site where the patient is located, they may have their own privileges and credentialing process for the telemedicine provider, or they can rely on the privileges and credentialing process of the distant site location. As long as the distant site location is either a Medicare participating hospital or a telemedicine entity that is not a Medicare participating hospital, but which provides services that enable the originating site hospital to meet all the applicable conditions of participation. Now, the Joint Commission requires both sites to be accredited, and what you also need is to have a written agreement between the two sites. And what this agreement would require is that the doctor at the distant site needs to be credentialed and have privileges at the distant site, but must be licensed to practice medicine in the state of the originating site. The originating site hospital needs to confirm that the privileges and credentialing process was performed at the distant location, and it should also receive periodic updates from the distant site hospital about the telemedicine provider. So if there's anything that the originating site hospital should know about that telemedicine provider, it needs to have access or be updated about that provider. The originating site hospital needs to conduct its own periodic reviews. It cannot just be standing by itself and not being active. They have to conduct their own periodic reviews and monitor the distant site physician's telemedicine encounters with its patients and report any complaints or any adverse outcomes to the distant site. And the originating site hospital needs to ensure that its bylaws permit this form of credentialing and privileging. So the originating site hospital must have ultimate authority over these decisions, the authority both to grant and to remove. Now, if you're dealing with telehealth and telemedicine settings outside of the hospital setting or outside what we just discussed, this is where you need to develop guidelines and protocols to govern how credentialing is actually done. So, standard of care. This is a big slide because this is clearly something that everyone focuses on from a risk management perspective. The guidelines for standard of care come from all over. They come from state law. They come from the state medical boards. They come from the Federation of State Medical Boards, the various medical societies. Some of these medical societies may be specialty specific, so you may see general standards of care. You may see specific specialty standards of care. The American Telemedicine Association. Standard of care is very, very important because those who are not proponents of telemedicine, the concerns that they typically are vocal about is the quality of the patient examination, the quality of care that the patient receives. They are vocal about the concern that the telemedicine encounter is with a provider with whom the patient has not yet established a relationship. You hear that the encounter may lead to fragmentation or non-integration of care, resulting in suboptimal care, for example, Could it result in the excessive use or overprescribing of medications? Could it result in inconsistent or contradictory recommendations or treatments between providers who are on the telemedicine hookup and those who are not? And then there are concerns about the qualifications of the remote provider. So these are always typically the things that you hear the detractors of telemedicine talk about, but they are important things to consider. And certainly when you set up a telemedicine encounter, you have to think about all these issues. So standard of care applies to a variety of areas. We've identified some of these on the slide. So for example, who provides the services at the distant site and who provides the services at the originating site? So for example, at the distant site, is a generalist or a specialist appropriate for that encounter? Okay, that could depend on the type of patient you're dealing with and on the type of condition you're dealing with. Also, depending on who's at the originating site. If you have the patient with a physician at the originating site, or you have the patient with a nurse at the originating site, or you have the patient alone in remote patient monitoring, how does this impact the standard of care for the distant site telemedicine provider? Do they have to do something different because the patient is by himself or herself, or is with a physician or some sort of other provider? Okay. Now, state law and payer guidelines do permit a variety of providers to provide telemedicine services. It's not just licensed physicians. It can be physician assistants, nurse practitioners, occupational therapists, chiropractors. There's a whole gamut depending on the state law. But again, at the end of the day, the provider that's being used at the distant site must comply with the standard of care. If it's not they have to comply with the scope of practice, and to the extent that they're not a physician, you have to determine based on state law whether they need supervision, and if they do need supervision, could it be remote or does it have to be on site? Okay. Now, at the originating site, you have the same issue. Okay. Should you have a doctor, or can you have an NPPA or an RN? Okay. And again, whoever you end up having needs to be consistent with the standard of care. Now, the various states and the payers, they impose limitations on what is an appropriate originating site, as Roy pointed out earlier, but they also may further limit the type of distance site provider permitted based on whether the communication is live versus store forward, or whether an in-person exam was done at the originating site. So all of these things are governed either by state law or by Medicaid and other payers. Psychiatric and telemental health, which will be addressed in a later webinar, they may have further requirements because of the type of patients they're dealing with and the type of care. The provider or the physician-patient relationship is critical. This is very, very important to assess, because the existence of this relationship, will result in an increased risk of liability exposure in either medical malpractice or professional misconduct cases. And the question is, well, how is that physician or provider-patient relationship created in a telemedicine encounter or in a telemedicine relationship? And different states, different payers will have different answers. Some will say that a relationship is created by merely identifying the patient, or by providing the patient with the provider's credentials, or by reviewing the patient's medical records. Just these activities alone can create the telemedicine relationship. Do you need an actual patient encounter? This is also state-specific. If you do need an encounter, does the telemedicine encounter create it, or do you need a prior live visit? The type of communication involved, whether it's synchronous or asynchronous, we spoke about those types of communication. Could that matter? Some states will say asynchronous communication automatically creates the physician-patient relationship. Some states may say that asynchronous, maybe, maybe not. And if you don't need a patient encounter, does a physician-to-a-physician consult trigger the relationship anyway? So here you're not even dealing with the patient, you're dealing with doctor to doctor. Different courts have held different opinions on this. And then finally, even if not required by law, should you have an in-person encounter regardless, because that is consistent with the appropriate standard of care. Now, if you look at various state laws and you look at different payers, they may specifically require that the telemedicine provider have access to or knowledge of the patient's history and the name of the patient's primary care provider. But typically what they say is that the telemedicine provider must conform to the standard of care that's applicable to the telemedicine provider's profession and as expected for inpatient care as appropriate for the patient's condition. So it is vague, but I think by applying traditional standard of care analysis and common sense, I think that can go a very, very long way in reducing the risk. What about in terms of examining the patient? That's always an important standard of care issue, okay? Is the patient examination that is being remotely performed consistent with the standard of care? Now, the distant provider can easily ask about the chief complaint or the history of present illness or the review of systems, the past medical history, the social history, and all that. But does the absence of touching the patient have an impact? Okay? Is there an inability to detect certain clinical conditions and features because you're far away? So, and do you have the appropriate devices that address these types of concerns? These are all things that must be thought of, because if there is an issue, okay, these are the first areas that are going to be targeted to show that this should have been a live exam, this should not have been a telemedicine encounter, and that a telemedicine encounter was inappropriate. A later webinar, we'll talk about prescribing, but if you look at many of the states' statutes, many states require that you need an initial in-person exam followed by periodic in-person examinations. So they're creating a standard of care. I mean, so these state statutes, these state regulations, Medicare, we're not even talking about reimbursement, but all we're talking about is, in order to have reimbursement, this is what you need, and by doing so, they're creating a standard that you have to comply with. And obviously, there are significant limitations in prescribing controlled substances. Technology and equipment, the quality, the type of equipment, the transmission speed. Do you have the appropriate equipment? Is the equipment functioning properly? Is it being used by correct personnel? Do the personnel have appropriate training? All that is part of the standard of care that you may not necessarily have in a traditional face-to-face encounter. Continuity of care is critical. Again, one of the largest concerns about a telemedicine encounter is there going to be continuity of care? Is there going to be coordination of care? And is there going to be appropriate follow-up care? You can't have this one exam or a series of examinations done in a telemedicine in a vacuum, and that the other providers have no clue what's going on. So these are the more significant issues that people look at, and most states actually do not address this component of the standard of care. It's really up to the professional's discretion, and it should be addressed in policies and protocols, and we'll discuss that a bit later. Now, patients must be able to get appropriate and necessary follow-up care and access to information. With the patient's consent, information should be disclosed to other providers. One thing we are constantly asked is, in a telemedicine encounter where you have multiple providers, which provider is in control? That's something that has to be addressed, because this is a liability exposure. There could be joint and several liability. So this issue needs to be clarified both with the patient to avoid a patient abandonment claim, and also with the other providers, so we know basically the chain of command. I think generally speaking, at a minimum, the telemedicine provider must operate under the same standard of care as for traditional face-to-face settings, particularly in how you obtain a history, perform the exam, review data, diagnose a condition, recommend a treatment plan, and follow-up. Okay, so the telehealth record. It goes without saying, again, these slides overlap, because you're having the appropriate telehealth record, having appropriate documentation is part of the standard of care. If you don't have it goes without saying that the telemedicine encounter must be documented, and it needs to comply with existing law, with payer requirements and internal policies and protocols. So what needs to be documented? Well, information that is recorded in a traditional encounter, but also information that is more unique to the telemedicine encounter. Now, if you look at Medicaid and other payers, what they typically require in documentation, they typically require the documentation to include at least the medical necessity of the service, the clinical encounter, and the informed consent. But the record must include more than that. For example, it should include the patient's location and the patient's state, because location is very, very important for licensure purposes, for reimbursement purposes, but also for liability purposes. Liability can be impacted by the patient's state, which, for example, in a medical malpractice claim, can control, the statute of limitations that's applied, whether there are any caps on damages, the informed consent requirement, and this is also important when deciding on the kind of professional liability insurance you need. Okay, what else needs to be documented? Well, the date of service, the informed consent, the clinical evaluations and results, diagnostic tests and results, prescribed medications and any limitations, any recommendations. This is all what you would typically see in a medical record. Back from many years ago, you would have to include this type of information. But what's also vital in a telemedicine document is to include information about any referrals, the coordination of care and follow-up. Again, these are the areas of weakness that people on the outside are going to be looking at, that are going to be judging, and that's why the document must include these components. Also, if there are any problems with the telemedicine encounter, if the patient has some complaints, there should be patient feedback. But also, if there were some problems with the personnel, or there were problems with the technology, that should be documented as well in some portion of the medical record. You will see, of course, with templates. We've been dealing with templates now with EMR. We have templates all over the place. The only advice that I can give you with respect to templates is do not be guided by the template. Don't let the template be your universe of questions that you ask, of what you do in the telemedicine encounter. Add additional relevant information. It's very, very important not to be limited by the template that you may be working with. And now, informed consent. So again, part of the standard of care. This is critical. This needs to be done prior, to providing the service. It must be documented. It should be consistent with relevant state law and with Medicaid and other payer reimbursement requirements. Today, I think roughly 40 states have informed consent requirements in their statutes or in their Medicaid policies. So what should the informed consent include? Well, it should include a description of the procedure and the scope of service. It should have the names of the healthcare professionals and the staff that are participating in the encounter at both locations, their credentials and locations, what technologies are being used. The patient should get a better understanding of what exactly is happening, what technologies are being applied, the benefits and the risks. That's obviously in any informed consent, traditional as well as in telemedicine, what alternative care is available and what are the consequences of not having the telemedicine encounter. But you should also discuss the risks that are heightened in a telemedicine encounter. So, for example, the limitations of the telemedicine encounter, some of which we may have discussed earlier with standard of care. So the patient examination the patient has to understand what are some of the limitations of the patient exam, and there has to be a meeting of the minds as to what the patient exam consists of, what the distant provider can assess. The patient has to be aware of these limitations. There are also privacy and security risks, and of course we have that even in a non-telemedicine encounter. But the patients should be informed that there could be unauthorized access by third parties, and they should be told that there are certain measures that are being taken to address and to mitigate them. They have to understand that there's no guarantee that it can't happen, but at least that we're aware of these things. We want to make you aware of these things, and we do have things in place to prevent this from happening. But we still can't guarantee that there won't be an unauthorized breach. You should also explain to the patients, and it should also be part of the informed consent, what technology risks there are that could impact the completeness and the accuracy of the information. For example, due to interruption of service or file corruption or transmission issues, and also that there are contingency plans in place to address these risks. The informed consent should describe the follow-up care, the coordination of care, and with the primary physician and with other specialists. And it should inform the patient that the patient can have access to records of the encounter. It should also tell the patient what information can or should not be transmitted between the patient and the distant provider. Sometimes you may have actual access, via email or other communication between the patient and the distant provider. And the patient should understand that highly confidential information should be very limited in electronic communications, and certainly emergency-related information would not be appropriate. They should go to an emergency room or some other facility. The informed consent should also should inform the patient that information will be disclosed to other providers, as appropriate with the patient's consent. And again, if the patient wants to use email communications, when email should be used, what's the content, what the response times. When patients use email, they expect the physician to respond literally 3 minutes later, and they get very angry when they don't get a response for a day. Again, there needs to be expectations. The patient's expectations need to be put on the table so they know exactly what to expect from these email communications with the distant provider, and just so that they understand that there may not be immediate responses. It could take several days. Billing, who bills and how, the patient's responsibility and coverage of payers should be part of the informed consent. And to the extent that any of the providers have financial interests, either in the devices or in the business, that should be disclosed. And finally, the patient's right to refuse or revoke needs to be mentioned. And again, if you're dealing with minors, then you have to comply with state law in terms of how to get a consent from a minor.
Okay, so I'm not going to go on to talk about some restrictions in the scope of telemedicine. Barry's presentation up to this point presupposes the broadening of telemedicine and the fact that it's becoming more and more permitted in the states and more accepted. There are, however, some restrictions that you have to be aware of, because these restrictions raise risk management issues. If you start to go too much into telemedicine, you may bump up against state or federal laws or other provisions that may give you some issues with regard to liability and licensure. So let's talk about some of the restrictions in scope. First of all, with regard to the Medicare population, there are still pretty significant restrictions on the use of telemedicine. The first restriction is it absolutely has to be real-time synchronous video. The Medicare program currently does not consider anything but real-time synchronous video to be proper, covered, or reimbursable. So that's the first point. The second point, which kind of goes into it, is that the patient needs to be physically present at a qualifying originating site. So the patient can't be in their house. They actually have to be at a qualifying originating site. And the Medicare regulations talk about what constitutes a qualifying originating site, both from the type of facility it is and from where that facility is located. The types of facilities are things that you would probably ordinarily expect: a hospital, a federally qualified health center, a rural health clinic, some type of other clinic, some type of physician offices. There's a series of different types of facilities, most of whom have to be Medicare participating providers that qualify as an originating site for purposes of Medicare. So that's the type of facility. There's also the location of the facility. The Medicare program has taken the approach that telemedicine is covered and appropriate to ameliorate the issues of health shortage. And that's the reason why you would use telemedicine. So as a result, the coverage for Medicare is only if the originating site is located in a health professional shortage area, one of those areas designated by the federal government as a health professional shortage area, or if it's outside, or if it's located in a county that's outside of a metropolitan statistical area. So it has to be in a rural or remote location, or a location where there's a health professional shortage, in order to have Medicare coverage for telemedicine. And then the payment is to both the originating and the distant sites providers. The payment is kind of divided between both of them. And we're going to talk about reimbursement at a later seminar, but basically the concept is Medicare is not going to pay for more than what it would have paid if it was a non-telemedicine encounter. And then finally, it's only for certain CPT codes. Medicare does not allow everything to be done by telemedicine, but only certain CPT codes. And to really be fair, Medicare throughout the last 5 to 10 years has expanded the number of codes in which they perceive to be appropriate for telemedicine, and so there's an increasing availability. For risk management purposes, even outside Medicare, it's useful to look at the codes that Medicare considers to be appropriate for telemedicine, because one of the issues with risk management is this a particular procedure that's appropriate for telemedicine. If it's listed on one of the Medicare codes as appropriate, that's pretty good support and guidance for the concept that it's a procedure or a diagnostic process that is appropriate to be done through telemedicine. So that's an important thing that you should look at. Medicaid and private payers look at this slightly differently in terms of the scope of telemedicine. Medicaid, CMS encourages telemedicine and has put out some public statements that they are encouraging the states to cover telemedicine to the extent, at least, of what Medicare does. But as you all know, the states have great discretion with regard to the Medicaid programs, and so there's many limitations or additional requirements in various states regarding the use of telemedicine and its appropriateness for Medicaid. So you have to be aware of what those limitations or additional requirements are. Sometimes those limitations have to be about what the informed consent has to say, what types of procedures are appropriate to be used for telemedicine. You have to be aware of those things. Private payer coverage is a plan-by-plan basis, right? But based upon the language of the plan, whether or not telemedicine would be appropriate and how telemedicine can be used. So if you're looking to roll it out for your private payer or your commercial payer population, you have to understand what the plans say. A number of states have what are known as state parity laws. And what those laws are, they're designed to encourage telemedicine. And what they do is they say that the carriers that are providing insurance coverage in that state must cover and pay for telemedicine encounters in the same way that they would pay for a traditional face-to-face encounter. And these statutes are designed to encourage the use of telemedicine. Now, these parity laws vary greatly. Some of them cover everything. Some of them cover only a few procedures. Some of them say that you cover them on the same basis, but don't say you cover and pay for them in the same basis. So it gives the carriers the ability to pay less for telemedicine services if they wish. But those are important laws, and the American Telemedicine Association is really lobbying for those laws to be enacted nationwide. So it's important to understand what your state's law is and what bills are pending in your state to understand where everybody is going in that area. Now, there's also some state law restrictions on the use of telemedicine that you have to understand. Most states, when they were looking to narrow or rein in the concept of telemedicine, focused on the in-person consultation requirement. And kind of Texas is the poster child for this. About 10 years ago, the Texas Medical Board adopted a whole series of regulations that were designed to limit the use of telemedicine. That said basically that a physician-patient relationship in Texas could only be established through the use of an in-person consultation. And then after that in-person consultation, there were only certain things that could be done in subsequent visits through the use of telemedicine. And it was really designed to limit the use of telemedicine in Texas. Teladoc, a big telemedicine provider, challenged those regulations. First of all, as irrational under state law, and then they brought a case under the federal antitrust laws, contending that the Texas Medical Board was inappropriately enacting these regulations not to promote the public health, but to insulate physicians in Texas from competition from telemedicine providers. This was a very hotly contested issue about 5 years ago. The federal antitrust enforcement authorities came down on the side of Teladoc and submitted briefs in the lawsuit supporting Teladoc's position, basically saying that the Texas Medical Board's restrictions were designed to be anti-competitive and had no real basis in protecting the public in Texas. As a result, Texas backed down, and the Texas Medical Board enacted a new series of regulations which did permit the use of telemedicine, synchronous two-way communications to establish a physician-patient relationship in Texas. And as a result of the whole Teladoc dispute, most states have now retreated from the concept of severely limiting telemedicine through an in-person consultation requirement. But you should check your state laws. And there are also other state laws you have to be aware of, such as psychiatry. Many states have restrictions on how telemedicine can be used in psychiatry. For example, there's a series of court decisions in Arizona that looked at the issue of whether or not, when you're doing a civil commitment hearing and you're having the physician do a two-physician certificate for civil commitment purposes, whether or not that physician could have examined the patient through a telemedicine system. And the courts in Arizona concluded, at least with regard to the Arizona statute, that use of telemedicine for a two-physician certificate was not contemplated by that state's civil commitment statute. So those types of restrictions are what you have to be aware of. Some of them require specific information to be obtained from the patient. For example, some states say that before a telemedicine encounter is commenced, there needs to be certain type of identifying information supplied by the patient so the provider is fully aware of who the patient is and the patient's identity. Those are all types of things you have to be aware of. It's a state-by-state requirement, and you have to be aware of them. Next, let's talk about there are certain restrictions that the Drug Enforcement Administration has placed on the use of telemedicine. Now, there's going to be a whole separate webinar on prescribing using telemedicine, but it's important to understand that for risk management purposes, that there are restrictions that the DEA has put on the use of telemedicine. So those restrictions are supplied by what was known as the Ryan-Haight Act, which was passed in 2008, and it was really designed to curb internet prescription abuse. That there are internet prescription mills out there, internet pharmacies, that on the basis of a questionnaire that a patient sends in, the pharmacy will have a doctor write a prescription for a controlled substance or some popular drugs, and there's really no in-person or any real medical examination that goes on. Ryan-Haight was a young man who was killed with overuse of one of these drugs prescribed by an internet pharmacy, and as a result, Congress passed the Ryan-Haight Act. And what it controls is the dispensing of controlled substances. It limits the use of telemedicine to dispense controlled substances. Now, it's important to understand that the limitations and exceptions set forth in the Ryan-Haight Act apply only if state law permits the telemedicine prescribing of drugs. There are certain states, I believe Barry alluded to this earlier, that flat out prohibit or severely limit the use of telemedicine to prescribe drugs, even drugs that are not controlled substances. If the state that the patient is located in has such a restrictive law, that law would control over the Ryan-Haight Act. So the Ryan-Haight Act and its exceptions only apply if the state law permits the dispensing of drugs through telemedicine. So the whole concept of the Ryan-Haight Act, first of all, is that the physician who is writing the prescription must have a DEA registration in the state where the patient is located. So this is kind of the parallel to the licensing requirements that Barry talked about earlier. You need to actually have an in-person, you need to actually have a registration where the patient is located. There has to have been at least an in-person exam, a prior in-person exam before you prescribe the drug, unless you can meet one of the telemedicine exceptions. And the telemedicine exceptions are, first of all, if the patient is located at a hospital that has a DEA registration, it's okay, and it doesn't have to be an in-person examination first. Secondly, if the patient is with an appropriate licensed practitioner, so like for example, if he's in a doctor's office with a physician who could treat the condition, and that physician is registered by the DEA, there does not have to be an in-person examination by the prescribing physician first. There's also an exception for Indian Health Service practitioners if there's a declared public health emergency. And there's also a provision in the statute for a special telemedicine DEA registration that provides that if a remote prescriber, a telemedicine prescriber, gets this registration, they're allowed to write a prescription without having any in-person contact with the patient. The problem is that the DEA has been very slow in writing the regulations for how you qualify for this DEA registration. So slow that Congress in 2018 passed the Special Registration for Telemedicine Act, which required them by October of 2019, the DEA to come up with registration provisions. They still haven't. So, this registration is being pushed by a lot of telemedicine providers on the concept that it will broaden the use of the prescription of drugs through telemedicine. So let's talk Now, turn it over to Barry about policies and protocols.
So policies and protocols are important because they will show, first of all, it's important in terms of providing the high quality care that you want to provide in an efficient and a continuous manner. But clearly, if you're being looked at from the outside, the first thing they're going to be looking at is to see if you have the appropriate policies and protocols and if you are in compliance with the policies and protocols. I always tell clients that it's better to have fewer policies that you're 100% compliant with than having multiple policies that you're only 10% compliant with. If you're not compliant with your own policy, that is already a per se liability. Okay, so where do we see policies and protocols, and what types of things do we focus on? Well, one is documentation. The policies should note that the originating site should get copies of the remote site's documentation. The originating site must have as much information as possible in terms of what care is being rendered to the patient who's at the originating site by the distant site provider. Okay, the informed consent, typically the distant site is the entity that gets the informed consent, but the originating site should get a copy. They should always get a copy of the informed consent, and typically we advise both sites, the distant and the originating site, to collaborate on the informed consent process and the documentation so that the originating site is satisfied with the quality of the distant site informed consent process. The policy must indicate that and must allow the patient to have access to records. It must address issues of maintenance such as archiving and retrieval, and it has to address the privacy, confidentiality, and security concerns and issues, and of course you need to be consistent with HIPAA and HITECH and any other appropriate state and federal law. The space that's being used for the telemedicine encounter at the originating site, that should have policies and protocols that govern the fact that the space must be sufficient to accommodate the patient, the personnel that are going to be involved, the equipment. It should be a private and an enclosed location. There should be policies about not allowing any cameras or cell phones. That has caused problems that we've seen when people bring unauthorized devices such as that. And there should be appropriate emergency care in case something goes wrong. There should be policies and protocols with respect to equipment and connectivity that address, for example, the availability and suitability of the equipment. That equipment is routinely tested and how it's maintained. Who is responsible for the testing? How frequently does this happen during the course of a year? And all these, of course, must be recorded and documented so we have a record of the testing of the equipment. So if something does go wrong, we can at least show that we were doing updates, we were testing, we did all the appropriate things, but something still went wrong that was out of our control. The policies must require backup procedures to be in place to ensure that there's uninterrupted services. There should be infection control policies, and we need to ensure that appropriate connectivity is present so that the transmissions are timely and complete. I don't think any policy and protocol book is complete without one that talks about patient rights and responsibilities. This should govern how patients are selected. Not every patient or medical condition is appropriate for a telemedicine encounter. So how patients are selected and how patients are identified, I think as Roy had mentioned earlier. Patient safety is critical. How are communications between patients and how are communications with patients and their primary providers and others handled? What should those communications include? They should include, for example, test results, instructions and education, information regarding follow-up and coordination of care and the need for further consultations. Again, the continuity of care is something that must appear in your policies and protocols because it shows that you're aware of those issues and that you're implementing safeguards to ensure that there is continuity and coordination of care. The policies must allow the patient to communicate complaints. So if there are any complaints regarding the originating site or regarding the telemedicine encounter, that is recorded, that incidents reports are created. Informed consent can be dealt with here. Again, there's a lot of overlap between this slide and the prior slides. And also that the patient should be able to access information via available technologies. Emergency care, simply stated, I think it's important for the telemedicine provider to quickly make an assessment as to whether you're dealing with an emergency situation or an urgent situation, and to the extent they are, they need to refer the patient to the appropriate facility, whether it's an emergency room or some other location. That is something that has to be done, and has to be done quickly and appropriately. Quality improvement is very, very important. QI. Those policies and protocols would typically require a periodic review to ensure that there is compliance by all of the players involved with the policies and protocols, and to the extent there's non-compliance, how are those corrected? We need to take corrective actions. There should be surveys conducted periodically, patient satisfaction surveys. There should be originating site satisfaction surveys. There should be the ability to record complications and adverse events. And these QI policies and protocols must require technology and backup assessments, a documentation review to make sure the appropriate documentation is being done, and also reviewing diagnostic accuracy of these services. And there should be policies with respect to training. A lot of providers are not comfortable with or are not familiar with a telemedicine encounter, and so these providers, physicians and others, and personnel and technicians, they should all be trained both initially and periodically in a variety of areas, whether it's patient communication and care, whether it's the informed consent process, whether it's what to document, how to maintain the privacy and security. Again, a lot of these are the same as in a non-telemedicine encounter, but they should also be trained in how to handle the technology, how to handle the equipment, and what to do in case there's a malfunction. And again, these will be discussed probably at later webinars, but there should be policies and protocols with respect to prescribing medications and billing. Let's see. Okay, we'll go to the next slide.
All right, we're going to skip over vendor contracts and go to some unique liability issues, some final risk management principles, and then insurance coverage. We've talked a lot about the liability and risk management issues all the way through, but just to talk about some other additional issues. Your liability is dependent upon state law, and there's a lot of issues about where the distant site is located and where the originating site is located. For example, if you're a physician in New York and you're treating a patient remotely through telemedicine that's in California, are you as a New York physician liable in California for malpractice or anything that goes wrong? And the answer is in most cases, certainly yes. That the California court, and there are cases that would say this, would say that the California court, even if that physician never stepped foot in California, would have long-arm jurisdiction to hear a lawsuit, a malpractice lawsuit, brought against the New York physician who's providing telemedicine in California, and also the institution in which that physician works. California law would probably apply, as Barry explained, using the applicable California standard of care and the unique laws in California regarding telemedicine. So this bespeaks the concept that physicians who are doing telemedicine to understand when they enter a state and treat a patient in that state, they're subjecting themselves to that state's laws, and that has to be fully understood right off the bat. There are other unique liability issues. You need to understand, is it an appropriate encounter to do telemedicine? Things may be such, as Barry pointed out before, where you need to have real hands-on or a close view of what's going on. And it may not be an appropriate encounter. The encounter may be too complex. The patient may be too sick. There may be other intervening factors that prevent the use of telemedicine. You have to be aware of that and take that into account. I'll refer you back to what we talked about before. A good starting point to determine what's appropriate for telemedicine is to look at the Medicare CPT code list. It's a good place to start. And then there's all the unique liability issues associated with using telemedicine equipment. And it's pretty clear right now, based upon some of the case law and some of the other licensing decisions that have come through the various states, that when you do telemedicine, both the originating site and the distant site is responsible for making sure that the equipment is working properly. That's a risk that you are undertaking, and that's something you have to make sure that Everybody who's using that equipment is ensuring privacy and confidentiality. That the medical device data system, the system that's being used for telemedicine, everybody's trained on it, it's operating properly, there's appropriate maintenance, backup systems in place. The other issue you have to be aware of is that these devices are regulated by the Food and Drug Administration. You have to understand what those registrations are and comply fully with the warranties and information that comes with the devices. Use them for the purposes for which they're intended. And this all bespeaks good risk management practices. For example, there needs to be quality assurance integration. So if you are a site and you have people on your site who are doing telemedicine, their telemedicine encounters should be incorporated into the overall quality assurance program of that site. So don't just limit yourself to looking at in-person encounters when you're doing quality assurance. Make sure you have an appropriate number of random telemedicine encounters. They're part of your practice, and you have to understand and make sure that you're providing good quality assurance. Also, make sure you have a protocol in place to determine whether or not the patient is communicating in an appropriate way in order that telemedicine will be useful. And instruct your staff that if they have any belief that they cannot provide a minimum quality service remotely through telemedicine, they have the absolute right and responsibility to terminate the encounter and require some type of inpatient examination. Also need to have telemedicine performance improvement monitoring. Do an M&M conference on telemedicine. Your practitioners who are doing telemedicine, the allied health professionals who are involved, have them discuss what went right, what went wrong, what can be improved through the use of telemedicine on a regular basis. Get that feedback and use that feedback to improve the way you deliver telemedicine. Take into account people's concerns and criticisms. Very important. Review and adopt treatment protocols to be used for telemedicine encounters. It's very easy in a telemedicine encounter to go through the encounter quickly and rotely because you do not have a patient there that you're interacting with on a personal basis. So it's important to have treatment protocols there to make sure that you cover everything that you're supposed to cover. You also need to, as I've said before, have full understanding of the equipment that you're using, make sure the equipment is up to date, make sure there's backup and contingency protocols. Last topic I'll talk about is insurance coverage issues. What you have to remember with regard to insurance coverage for telemedicine is that your policy may have geographic or jurisdictional limitations. So if you are sitting in New York and you're providing telemedicine services to a patient in California, your New York policy may not cover it. You have to talk to your carrier, have them look at your policy, make sure that there's some type of remote site coverage and that it will cover you providing services in the remote state. The best is to have a policy that specifically includes and covers telemedicine, okay? The second best thing would be to have a policy that does not specifically exclude it. But in order to be fully covered, it has to specifically include telemedicine. You also have to understand and make sure that there's coverage for negligent credentialing. You may not be in control of the credentialing at the remote site. You have to make sure that you have coverage if there's a claim against you for negligent credentialing. You also have to understand and make sure that the carrier has the ability to write insurance for the distant state. You have to understand if there's any changes to your limits of liability or self-insured retention through the use of telemedicine. Finally, what you need to understand is whether or not there's going to be coverage under your malpractice policy for things like equipment malfunction or privacy issues or anything that goes wrong with the equipment. Very often, medical malpractice policies will not cover that. So you have to also have a cyber risk policy and a general liability policy that covers for these risks. And then you have to have an insurance professional look at and understand how all these policies will interplay with each other. question becomes, is all this going to cost you additional amounts of money? The answer is that carriers are still charging more money for telemedicine riders, telemedicine policies. Well, there is a significant amount of discussion in the literature that what studies have been done as to whether or not there's an increased risk when you use telemedicine, and the answer is that there is not. And in fact, there are some studies out there recently which show that telemedicine or practicing medicine through telemedicine is inherently less risky than in-person encounters. So if you are going to embark upon a telemedicine program, make sure you engage your insurance professionals and understand what your liability insurance policy does and does not provide.
All right, so we're at 1:02, so we apologize for running a little bit over. There are lots of questions, which is great. Please, you have our contact information. Give us a call, send us an email. We'd be more than happy to answer your questions in detail at your convenience. Again, thank you very much and have a good afternoon.